First of all, I'd like to thank the organizers, Dr. Righetti, and all of you for allowing me to participate via a video conference. I think we can use it also in the future if it works well. We will talk about some of the possible treatments. Certainly, there are many techniques that can help. We can have corneal inlays, monovision. I will focus on monovision. In monovision, well, we have some difficulties hearing you. Perhaps you should speak closer to the mic. Well, I can talk louder. Is it fine like this? Yes. It is a method which implies that the dominant eye is used for distance vision and the non-dominant eye is used for near vision. The literature is quite positive about monovision. It says that 95% is patient satisfaction and 92% reach of the patients need reach 6 lines, read up to 6 lines. Stereopsis is very good, and there is very good intermediate vision with just a few complications. Monovision can be obtained with several techniques, even with spectacles, though it's a bit difficult. You can more easily reach monovision with contact lenses. Or you can use LASIK, the LASIK technique on the cornea, or PRK. Intracorneal inlays perform quite well, but not exceptionally. After phacoemulsification, if there is a cataract, lenses work well. In monovision, multifocals don't really have a sense because of the reasons you know already. And phakic lenses are a very interesting method. Indeed, new generation lenses work very well. If you have a myope age 25 with 12 diopters to be corrected, you use a phakic lens. And the same is true for a 45-year-old presbyope. Let's see when a technique should be used. There are 3 techniques, basically, with good results and good safety margins, both for patients and physicians. The LASIK technique is good for young presbyopes with medium to low refractive defect, up to 6-7 diopters. The phakic IOL is good for young presbyopes with a high refractive defect. You can correct this with a phakic lens. These are very accurate procedures with good quality of vision and very low risk. As an alternative in older patients, in patients with refractive errors that want to be more independent, patients who are aged 55 or 60, then they can undergo monofocal lens surgery. Just to be clear about this, let's see a couple of clinical cases, very easy ones. This is a 42-year-old patient, hyperopic, 4 pairs of spectacles, tired of changing them because he can never find them. He would like to be independent of spectacles. He's got these values on the left and on the right, very good near vision correction. What did we do for correction? We did femtolasic for monovision, and this is the result. 10 on the right with very good distance vision. On the left, he's got -1 for distance vision. Its vision is very good for near vision. The result is that the patient complains of no refractive difference, is independent of the spectacles, requires no distance correction for the left eye, unless he has to drive long distances or goes to the cinema, and the patient is highly satisfied. Another case, this is a 49-year-old myope, 5 diopters on the right and 4.5 on the left. The left eye is the dominant eye. The lens is clear. It's a pity to remove a lens at the age of 49 if very good results can be achieved with a simpler technique. We did femtolasic for monovision. We obtained minus 1.75 on the right because he's got more presbyopia. And in fact, on the left eye, 10. The patient complains of mild refractive difference disorders initially. The patient is independent of spectacles in daily activities, requiring correction, distance correction for the right eye when driving or going to the cinema. The patient is quite satisfied, so we were able to correct myopia and presbyopia without being too aggressive. If the patient has a cataract, like in this case, we're talking about a myope, but it's also true for hyperopes and astigmats. This guy has these values: medium density cataract, good fundus. Well, this patient might even be suitable for multifocal lenses, but myopes don't like multifocal lenses very much. We use femtosecond laser in all our cataract surgery cases when we put in a monofocal IOL for monovision. The result is this one: very good vision recovery on the right, independence of the glasses, and actually the patient is almost always without correction. Unless he has to read a book for 1 hour, then he needs spectacles. Or if he has to drive from Milan to Bologna, then he has to wear spectacles. But apart from this, he's very happy. I showed you 3 simple, satisfactory cases with good correction using monovision. Now, some data on monovision. It's useful because you can correct the refractive defect in both eyes. For distance vision, you correct the dominant eye for far vision, and you leave the non-dominant eye with moderate myopia. The optimum thing is to have J2, J3 in one eye and 10/10 in the other. Well, optimal refraction changes depending on the age, because the residual refraction changes depending on age. If you're young, you leave little refraction, you leave a bit more if you're older, increasing with age, considering also the patient's needs. Basically, monovision is a good way to leave patients independent of their spectacles in daily activities, not requiring constant use of binocular vision, for example, using tablet or PCs. What are the limitations of this technique? Well, at times you still have to use spectacles when driving, especially at night, for reading, for a long period of time, and also for visual tasks that are highly performing. But monovision allows you to use your sight in a comfortable way at home, when driving, or at work. You have to give up something, for example, the binocular balance, the maximum visual acuity, but you are independent of optic correction for most of the day, and many patients actually want precisely this. The benefits are that it's consistent optical correction. There is good binocular adaptation after a few weeks training. There is poor anisocony as compared to glasses, and independence of contact lenses. It would be good for patients who've worn contact lenses for a long time and can't wear them anymore. Now, problems, the binocular visual acuity is slightly diminished. Slightly diminished is also contrast sensitivity with mild reduction in stereopsis. However, this is really quite well accepted by the patients, so it's a positive fact. One should always explain things very clearly to the patients. One should explain what monovision is about and what the goals of the procedure are. You need a highly motivated patient with a certain type of visual activity with adequate age. You have to consider the patient's personality, and also visual acuity has to be good because you can't give monovision to people who only have 3 or 4 lines on each side. Before surgery, you have to simulate the result using contact lenses so that patients appreciate what we're going to do and the final result. This is not possible in the case of cataract, but in patients aged from 40 to 55, when there is no cataract, you can do this. Contraindications are patients requiring excellent stereoscopic visual acuity and patients who use their eyesight for many hours to do certain things. Without going in depth into the contraindications, we can say that, as we heard from the previous speaker, dozens of techniques are possible, but those performing really well are just a few. The fact that so many techniques are available means that they're not perfect. If they were perfect, we would just need 1 or 2. One should wonder, therefore, which technique should be used. Which is the technique that maintains the existing accommodation? Which is the technique that does not change the quality of vision very much? Which is more predictable, easier to perform, low risk, reversible, or with low complications? You have to analyze all these points before undertaking or embarking on any surgery for presbyopia. I think monovision meets many of these requirements, providing the patient with good independence of optical aids. We use many other systems for the correction of presbyopia, but we like monovision very much. And that's it. Thank you very much. If there are any questions, I'll be pleased to answer.
Ci sono domande da...
Are there any questions to Dr. Buratto? There's one here.
Dimmi.
How do you assess the dominant eye? Which is the examination that helps you decide about the dominant eye? I ask the patient whether he or she is left or right-handed. Then you can ask, for example, which eye is used for taking photographs, or whether he uses a monocular lens in a certain way. There are, for opta systems, well, there are many ways to assess the dominant eye.
Ci sono altre domande?
Any more questions from the floor?
Sono Roberto Bellucci e ho una domanda per te.
My name is Roberto Bellucci. I have a question. When talking to the patients, do you mention that the procedure is reversible, or do you think that the patient may not like the idea that it's reversible? I don't usually mention that. I don't say that the technique can be changed and modified. Sometimes it happens. This week, I had a patient who remained in monovision for 3-4 months. I performed a LASIK on him. At some point, he decided he did not like the technique. We reversed it with the laser. The patient is very happy. He has his visual acuity for seeing at a distance and uses glasses for reading. I think you can change the procedure with techniques that are not very aggressive. Even with the latest generation multifocal lenses, you may have some residual astigmatism or other problems interfering with comfort. Using excimer laser in those instances may be helpful. We have this possibility as refractive surgeons. We do a lot of refractive surgery, so we have this advantage. We can meet almost all our patients' needs. All patients' refractive needs. Thank you very much, Lucio. It was very interesting. There are no more questions from the floor.